Chemotherapy and related therapies. Chemotherapy. NB. Chemotherapy should kill a tumor but enable damaged normal tissues to recover between treatments. The cumulative effect should be to maximize tumor damage but minimize normal tissue damage. Principle. Chemotherapy can be designed to make a disease disappear, e.g. acute myeloid leukemia, AML, or acute lymphoblastic leukemia. Suppress the disease, e.g. the plateau phase in myeloma. Normalize the blood count, e.g. essential thrombocythemia. Merely improve the blood count with no intention of cure, e.g. palliation in certain cases of AML. A complete remission is defined as the disappearance of the disease from blood and marrow, although molecular techniques may still reveal traces. Partial remission is defined as an improvement in blood and marrow with significant residual disease. Chemotherapeutic agents usually damage cells during cell division. Combining agents that act on different parts of cell division will maximize cell damage. However, within a tumor some cells will not be dividing and can therefore be relatively resistant to the effects of chemotherapy. Thus, if a tumor has a high proportion of dividing cells, such as high-grade non-Hodgkin's lymphoma, NHL, it is more susceptible to chemotherapy. More indolent tumors, such as low-grade NHL, are less susceptible to chemotherapy. Note that low-grade NHL has a better survival than high-grade NHL because it is less aggressive even though it is less chemosensitive. Chemotherapeutic agents and their properties. Alkylating agents. These include cyclophosphamide, chlorambucil, busulfan, and melphalan. They transfer alkyl groups to DNA, resulting in double-strand linking that prevents cell division. High-dose intravenous cyclophosphamide can cause hemorrhagic cystitis, so mesna is infused to limit bladder damage. Myelosuppression, alopecia, and emesis are all common with cyclophosphamide. Oral chlorambucil and melphalan are well tolerated. They produce some myelosuppression but rarely cause significant emesis or alopecia. Anthracyclines. These include adriamycin, doxorubicin, and mitoxantrone. They were originally designed as antibiotics and inhibit topoisomerase II, a DNA repair enzyme, and also intercalate DNA base pairs to disrupt DNA templates. They are usually given intravenously and cause major myelosuppression, emesis, alopecia, and mucosal damage. Cardiotoxicity is significant, and transient ECG changes occur in 1/3 of patients. Patients should not receive more than 450 mg/m2 of doxorubicin during their lifespan as cardiomyopathy and heart failure are dose-dependent. Vincristine. Vincristine and its relatives crystallize cytoplasmic tubulin, preventing spindle formation and cell division. These drugs do not cause significant myelosuppression, alopecia, or emesis. However, nerve damage may produce paresthesia, foot drop, ileus, and constipation. Vinblastine should replace vincristine if neurological toxicities are problematic. Antimetabolites. The antimetabolite group of cytotoxics comprises a number of very different drugs, including methotrexate, cytarabine, and fludarabine. Methotrexate inhibits dihydrofolate reductase, which paralyzes the folic acid and B12 metabolism central to purine or pyrimidine formation. Methotrexate is often used in low doses by rheumatologists. Always be vigilant for sudden and potentially fatal myelosuppression. Intrathecal methotrexate is given in some high-grade lymphoid malignancies that may be present in the cerebrospinal fluid. High-dose intravenous methotrexate typically causes myelosuppression, damages the gut mucosa, causing mucositis and diarrhea, and produces renal impairment. Folinic acid rescue is given intravenously to minimize the damage to normal tissues. Folinic acid bypasses the methotrexate-sensitive step. Alopecia and emesis are not common. Cytarabine, cytosine arabinoside, is a pyrimidine analog. It becomes incorporated into DNA and terminates DNA synthesis by inhibiting DNA polymerase. It is a major player in the treatment of acute leukemia. It is myelosuppressive, emetogenic, and produces mucositis. Occasional cerebellar damage and conjunctivitis are seen. Fludarabine is a purine analog that is converted to fludarabine triphosphate within the cells. This inhibits ribonucleotide reductase and curtails DNA synthesis. Fludarabine is given orally with very little toxicity apart from myelosuppression. It forms the second line of treatment in chronic lymphatic leukemia, CLL. Hydroxycarbamide, hydroxyurea. Oral hydroxycarbamide is widely used in myeloproliferative disorders. It may cause drowsiness but is otherwise very well tolerated. Careful dose adjustment limits marrow suppression. Hydroxycarbamide inhibits ribonucleotide reductase. Asparaginase. This is an unusual drug. It hydrolyzes asparagine and inhibits protein synthesis. It may cause hypersensitivity, pancreatitis, and somnolence. Myelosuppression and emesis are not major problems. Others. Steroids have a cytotoxic effect in certain lymphoid malignancies. Their exact mode of action is unclear, but they probably destabilize the nuclear membrane. Etoposide, VP16, is a semisynthetic derivative of podophyllitoxin. It is a topoisomerase II inhibitor that produces myelosuppression and emesis. NB. A dedicated chemotherapy pharmacist can make life simpler and safer for everybody. Over the last 30 years, different combinations of chemotherapeutic agents have been used in hemic malignancy under the guidance of the Medical Research Council. Gradually, improvements in survival and toxicity have been produced by this coordinated approach. Such national and international initiatives enable statistically significant patient numbers to be obtained and are thought to be best practice in cancer units. Dose scheduling. Finding the correct dose and schedule for drug combinations is very dependent on the limiting toxicities. Dose is calculated according to body surface area. Myelosuppression is the commonest toxicity that limits therapy. Marrow function should recover sufficiently between courses before further treatment. Marrow transplantation is a technique that uses supralethal chemotherapy, plus or minus radiotherapy, to kill residual tumors, after which the patient is rescued by an infusion of bone marrow or stem cells. NB. What is the best way to conserve renal function during chemotherapy? What advice should be given about fertility? Cytokine therapy. Erythropoietin. Erythropoietin is very effective in the treatment of the anemia of renal failure. In hematology, it can significantly improve the anemia of myeloma, especially if renal impairment is present. However, it does not consistently improve the anemia of myelodysplasia or chemotherapy and is only used in selected cases or trials. Colony-stimulating factors. Colony-stimulating factors were discovered in the laboratory to stimulate granulocyte growth, monocyte growth, or combinations of both. Given subcutaneously to patients, they boost the recovery of such cells following chemotherapy, transplantation, or severe infection. There are many clinical studies using such agents, and the broad picture is that although infections can be reduced, overall survival is not improved. Interleukin-2. Interleukin, IL-2 stimulates the division of cytotoxic T cells and improves immune function. In the 1980s, IL-2 was used in high doses in cancer patients, with major toxicities. Smaller subcutaneous and intravenous doses are now being examined to see if the agent can stimulate the natural host response to suppress any residual disease following chemotherapy. Interferon alpha. This has been used clinically for over 30 years. It has not been a panacea for cancer. In modest subcutaneous doses it can improve and control hairy cell leukemia, chronic myeloid leukemia and hepatitis B and C. In younger people the influenza-like symptoms it causes are well tolerated and disappear after a few weeks. The elderly do not tolerate interferon alpha very well. High doses have been used in renal cancer and melanoma with improvements in about 30% of cases, but there are major toxicities at such doses. Monoclonal antibodies. In recent years the use of monoclonal antibodies, antibodies directed at antigens on tumor cells that bind to the antigen and damage the cells, either by antibody cytotoxicity or by direct killing, has increased dramatically in hematology practice. Although these are not, strictly speaking, chemotherapy agents, some newer monoclonal antibodies may be conjugated to a drug or may be radiolabeled for better efficiency. Side effects may occur at the time of infusion and are generally mild and manageable, fever, rigors, and urticaria, but may occasionally be severe, hypoxia and hypotension. Infusions are usually started slowly for this reason. Late side effects mostly relate to immunity and infections. Currently the most commonly used include the following. 1. Rituximab, anti-CD20. CD20 is widely expressed on most normal B cells and B cell malignancies. This agent is now recommended as part of first-line therapy, with chemotherapy, in patients with diffuse large B-cell lymphoma, and is approved by the National Institute for Health and Clinical Excellence, NICE, for use in this setting. The evidence for its efficacy in numerous other lymphoproliferative diseases is accruing fast and the applications for this agent are broad. 2. Alemtuzumab, anti-CD52. This agent is used extensively in stem cell transplantation as a T-cell depleting agent, although it also depletes B cells, natural killer cells and dendritic cells, which all express CD52. It has also been used with some success in CLL. 3. Gemtuzumab ozogamicin, anti-CD33 with anti-tumor antibiotic. This agent is being investigated in AML and is being used in a number of medical research council trials. NB. Chemotherapy will decrease fertility, so think about freezing sperm or eggs. Fertility may return after chemotherapy, so contraception is required. Chemotherapy should be accompanied by plenty of intravenous fluid and allopurinol to protect against urate nephropathy. Complications. NB. If you are worried about extravasation of chemotherapy, seek expert advice. Major myelosuppression can result in rapidly fatal infections. Early use of broad-spectrum antibiotics is important in this situation. Sterilizing the gut also reduces the risk of gut flora causing septicemia. There is no effective way to minimize alopecia. Modern emesis control with 5-hydroxytryptamine, 5-HT3, antagonists means that chemotherapy is much better tolerated, and patients rarely have to be deeply sedated. Infertility. Fertility is permanently lost following some treatments such as allogeneic stem cell transplantation. In such cases, this must be discussed with an honest but sensitive approach before treatment. All men, even those who have no plans for starting a family, their views may change, should be offered the chance of sperm storage before starting chemotherapy. This process is usually carried out over 3 days, and the delay is usually acceptable in terms of starting treatment. For women requiring chemotherapy, storage of eggs or embryos, created by in vitro fertilization, is possible, but these processes require ovarian stimulation and usually take weeks. In acute leukemia, this length of delay before starting chemotherapy is not possible. Storage of ovarian tissue is at an experimental stage at present, although there is the concern that reimplantation of ovarian tissue taken before chemotherapy could be associated with the reimplantation of leukemia. Ovarian tissue storage may also be impractical because of the need to start chemotherapy immediately. Many women who do regain fertility after chemotherapy go on to have an early menopause. Tumor lysis syndrome. This is a medical emergency with a high morbidity and mortality. It should be anticipated and prevented, but if it occurs, treatment should be prompt and multidisciplinary, e.g. involve the renal physicians and/or intensivists. Tumor lysis syndrome occurs because of the rapid breakdown of the tumor, which results in metabolic derangement, hyperphosphatemia, hypocalcemia, hyperkaliemia, and hyperuricemia, and clinical features, oliguria, cramps, seizures, cardiac failure, and arrhythmias. All patients at risk should be adequately hydrated prior to and during chemotherapy. Those at high risk should receive rasburicase, a urate oxidase enzyme that results in rapid degradation of uric acid. Others should receive allopurinol. Blood tests should be done after chemotherapy to detect abnormalities.